So welcome to our Lymphoma Action and Leukemia Care webinar on living well on active monitoring.
Hello everyone, my name is Adam Mead. I'm a haematologist in Oxford, so I particularly look after patients with myeloid diseases, myeloproliferative neoplasms and related conditions, and I also run a research group at the University of Oxford.
Thank you. And Chris?
Hi, afternoon everybody. My name is Chris Fox. I'm a consultant haematologist in Nottingham, and I do the opposite of Adam in terms of the disease spectrum, mainly focusing on patients with lymphoma and CLL, and also very actively involved in clinical research.
And we've got John on the phone. We've got two people affected by different types of lymphoma and leukemia, and so we've got John on the phone.
Hello. Sorry you can't see me, but I'm stuck on an island off the coast of Anglesey, so the technology is a bit rough. I've had chronic lymphatic leukemia for 19 years, and I've been active monitoring all that time, apart from a short period of time where I was having infusions. But perfectly happy, perfectly well, and very happy to join you all this afternoon. Thank you.
Thanks. And Denise?
Hello, everyone. For whatever reason, IT gremlins today. I've been living with non-Hodgkin's lymphoma since, well, before 2009. That's when I had my first set of chemotherapy treatments, and I've been on active watch and wait since 2010, so for the last 11 years. So I know exactly what it's like when you have the call to go in for the consultation to sort of see how you're going, and I look forward to supporting others. Thank you.
Thanks. Okay, and then so I'm Stephen Scowcroft. I'm Director of Operations at External Affairs at Lymphoma Action, and very pleased, I'll let Nick introduce himself from Leukemia Care very quickly. And this is a series of joint webinars that we've been doing over the last few weeks and months. Nick? Nick, you're on mute.
Hi everyone, I was muted, still doing it a year in. Yeah, I'm a patient advocate working with Leukemia Care as Healthcare Liaison Officer.
So we're going to come straight in. So this is really for kind of for Adam. So just give an overview really about for what types of blood conditions might active monitoring be used, and why it is kind of used as a treatment.
Yeah, so that's a good question, and there could be quite a long answer, but I'll try and keep it fairly briefly. So people with blood cancer, there's obviously a very broad range of different types of blood cancer, and across the spectrum really of the different types, there's potentially a role for active monitoring. So that goes from patients with chronic lymphocytic leukemia and certain types of lymphoma, and across the board to myeloid diseases such as myelodysplastic syndromes, myeloproliferative neoplasms, and some less well-known types of illnesses like systemic mastocytosis and certain subtypes of leukemia such as hairy cell leukemia. And there's a range of different diseases, but the broad principle is active monitoring is used in a situation where someone is diagnosed with a form of blood cancer, where it's thought that the risk of that disease progressing is potentially quite low, and the risk of starting the treatment might outweigh the benefits of starting the treatment. And it's also used, so that's the kind of broad answer. It's also used sometimes in a situation when people are recently diagnosed, and I think the clinician, and in a conversation with the patient, might want to just have a period of time just assessing things, rather than rushing to make a decision. One might want to just take a few months just to assess things, to get a feel for what the impact is of the disease in any particular person who's affected by it, and also get a feel for the kind of dynamics and the trajectory of the disease in that person, because that can vary quite a lot from person to person. And sometimes just a period of time actively monitoring the disease, getting a feel for where it's going, and getting a feel for how it's affecting the patient, that can be really, really helpful to judge the management going forward.
Thank you. I think I just was going to point out, it's fair to say this active monitoring isn't only used within blood cancer. There are other cancers that active monitoring is used as part of the treatment kind of pathway and toolbox. And again, just to reiterate, we're going to be talking about active monitoring here because both leukemia care and lymphoma action kind of using that as the term. You may hear it as watch and wait, or more kind of negative connotations that kind of watch and worry, but you know, we're in all of our information, we're kind of taking the position to talk about it in the positive way that it is, which is about active monitoring, and that will become more apparent as we go through.
Chris, what the active element that we're obviously meaning to promote with the language and the term, what makes active monitoring active? And also, one question I just wanted to ask that was raised, sorry to interrupt you, was in what settings, you know, which health professionals are involved in active monitoring? Is it secondary care? Is it primary care? Is it both? Sorry to split the question there.
Yeah, so it's a great question, and one that we discuss with our patients extensively in the early stages following diagnosis, because the concept of so-called watch and wait or active monitoring is not always the one that rests easily with patients. And I think it's important to say that this is not doing nothing. We're not, you know, watch and wait. Active monitoring is a positive, active process. And as Adam has said, it's generally applied in the first place, or recommended in the first instance, because we think that the balance of risks and benefits is much more in favour of just monitoring, and rather than actively intervening with potentially toxic drugs that at that stage of the illness are unlikely to give a significant benefit. So, and I think taking an active approach is good in terms of engaging the patient themselves, because the most important person is the patient with the condition. But it also involves other people, their family and friends, who may notice aspects about an individual that they may not notice. Somebody may be losing weight without realising it, and a close family member is often a good person to notice changes in appetite or weight loss, for example, or energy levels. Clearly, it also involves health professionals. You have your medical team with your named consultant, but another group of people that are invaluable to Adam and I, both in terms of our day-to-day work, but also in terms of the patient communication and experience, are the clinical nurse specialists. So these are a really important group of people who are often the first port of call for a question regarding active monitoring. You know, should I worry about this? Is this important? And so on. And then we have primary care, and I think patients' relationships and access to their GP services differs quite a lot geographically, even within our own area in the East Midlands. We have, patients with many different relationships and experiences with their own practice. Some GP practices are very engaged and happy to perform blood tests, and even occasionally interpret the blood tests within our guidance, whilst other GP practices perhaps are happier just to leave all of the medical input to the primary hemato-oncology team. So I think that's one aspect that varies a lot, but I think it's important that we communicate with GPs, and we would do that through clinic letters and other means. But an individual patient will have their own individual circumstances in terms of who they live with, who their close family and friends are, how connected they are to their GP practice, and there'll therefore be a variability in someone's dependence or need for the direct input from the hematology team. So that's a long answer to a shorter question, but they're my initial thoughts.
Going back to Adam, are there any particular guidelines that people follow, and perhaps you can expand a bit more on that? Why isn't treatment used straight away, or how do people kind of know where they are on active monitoring? As you said, it is a positive process, but perhaps it's not kind of like a treatment plan where you know where you are at different stages. So how do you kind of put that across to people in the early stages?
Yeah, I mean, I think the process that you know, for any situation in a person that's just been diagnosed with a blood cancer is, first of all, you want to establish the diagnosis, make sure the diagnosis is clear and you've got the disease classified correctly. And then you want to kind of personalize the situation, understand what the implications are of that diagnosis in an individual patient. This is something called risk stratification. So what that means, and this will apply across the board with different types of blood cancers. So you make the diagnosis, and then you go through the process of risk stratification. So what that means is you draw in a range of clinical variables, so the symptoms the patient might have, you know, blood count and blood test results, maybe the results of a bone marrow test if that's been done, and more you incorporate the results of molecular tests and other more kind of sophisticated laboratory parameters into that mix. And that gives you a really detailed assessment of what the implications are for any individual person. And that allows you to do this process of risk stratification. So broadly, you can classify a particular individual with a blood cancer into those that are what you might describe as higher risk, so those that are more likely to progress and therefore need some kind of intervention sooner rather than later, or immediately in some cases. And those cases you might classify as lower risk, where you might make the decision to recommend active monitoring. But again, it's important to say active monitoring is really not doing anything. You know, in the case of myeloproliferative neoplasms, for example, the low risk patients will undergo active monitoring, so they won't have any kind of chemotherapy treatment to bring their blood counts under control, but they will, for example, very often receive aspirin, and we will very strongly recommend very careful control of other vascular risk factors, so checking the blood pressure, checking the cholesterol from time to time, diabetes screen. So there are other things that are kind of woven into that, even though there may not be active targeted treatment for the disease.
Yeah, and again, it's worth just reiterating, and in the same way that there are particularly national guidelines and pathways for a particular type of lymphoma or a particular blood cancer disease area for going into treatments, what you might have first. Active monitoring is part of that, those pathways, aren't they? So these are within this kind of question where it doesn't vary from individual to individual, clinician to clinician. It's part of the national guidelines.
Yeah, I didn't draw it back to your original question. That's very true. So this process of risk stratification is definitely woven into any disease group. Has got in the UK, it's got a set of guidelines, and there are international guidelines too. And those guidelines will set up how you accurately make a diagnosis. The criteria are how you accurately risk stratify patients and which patients you should select for the active treatment versus active monitoring. So those are pretty clearly set out across the board in all the different types of blood cancer. So that broad process that I've set out is specified in much more specifically for each individual blood cancer in national and or international guidelines. That's correct.
I think maybe this first question that's actually on the list gives us a great opportunity to ask Denise and John some perspectives as well. You know, from a patient perspective, I'm sure patients ask the question in the beginning when they're prescribed active monitoring, learning who does the monitoring, and maybe the clinicians can come back and share that aspect. But John, perhaps you could ask, as you've been on active monitoring for quite some time, how are you involved as a patient in the process of active monitoring, and how are you able to be participative and proactive in the process? Are you able to share that aspect of active monitoring?
Right. Yeah. When I was first diagnosed, obviously, the one that you don't hear anything, you're just scared, and it takes a long time to settle down and come to terms with what's happening to you, and then nothing happens to you, and then you have to come to terms with that. And so the watch and wait wasn't clearly explained initially, but you hear about people fighting cancer. Well, I kind of came to terms with the fact that you don't fight it, you try and live happily with it. And through total faith in my medical helpers, I let them get on with all the technical things. They take my blood every 3 months, and in the meantime, I've just got to make sure I don't get ill. And I think the most important thing for me is to live happily with leukemia is keep healthy, get as much exercise as I can, including getting very tired through exercise because I sleep, and make sure I eat well and try and remain as stress-free as possible. That's not been easy over the last year without going into details, but it's look after yourself, get on with it, and make sure that nobody has to start prodding you with needles and giving you chemicals. So if the option is to do active monitoring or to go into something a little bit more severe, it's look after yourself and just get on with active monitoring and hope for the best. And I've been hoping for the best for 19 years, and I'm still here laughing about it.
Thank you, John.
Is that okay, Nick? Was that clear enough?
Brilliant. Thanks for sharing that. And I'm sure Chris will be able to touch on how he involves patients in active monitoring. Maybe Denise, I think you have a slightly different pathway. Are you able to explain how your care team involve you in the active monitoring process and how you are involved in this?
Hello there. Well, obviously the CNS is my first port of call. So in between my consultation sessions, which are every 3 months, along with the bloods, I know that I can sort of call upon the CNS if I've got any concerns. I would say that my family are hugely involved because they are indeed the sort of outside source that really does more monitoring than I can, in that they do notice my energy levels, if I've got weight loss, and I also have a very noticeable lymph node which seems to sort of swell. It goes up and down, waxes and wanes on my neck. So they're the sort of signs that my family can sort of prompt me about, and will also come with me to the consultation, so they can sort of inform the consultant as well about how I've been doing. So I hope that's sort of helpful to others.
That's really helpful, because I think it's important to know, to understand how patients and family and friends can be involved in the active monitoring process. And I guess as patients, and I've heard patients ask the question, who actually does the monitoring? You know, when patients may not see a patient, their clinician very frequently. Chris, if you've got anything to add there as a clinician providing the care for an active monitoring, how you work with your patients and your team?
Yeah, so I think a couple of things to say. The first is that I think although the principles of active monitoring are very similar across the range of blood cancers that Adam described, for an individual patient, the precise or the most valuable ways to monitor a condition could be quite different. So, for example, patients with a chronic leukemia, for example, CLL, or perhaps one of the chronic myeloid neoplasms, a blood test in those situations is probably the most important method of monitoring. and that's a very clear indication of how the condition is behaving over time. And whereas blood tests for other patients, for example, patients I look after with low-grade lymphoma, such as follicular lymphoma or marginal zone lymphoma, may have entirely normal blood tests, and although they have some value in diagnosis and monitoring, they are not the most important method. And so in those patients, we focus much more on clinical signs, so patient's well-being, the presence of lumps and bumps, the emergence of significant weight loss or drenching night sweats, are much more important triggers to maybe bring forward a clinic appointment or to consider doing a scan. And so you can see that between two patients, you could have very different ways of actively monitoring the condition. So individualizing and having for the patient to understand for their particular condition what are the most important ways of monitoring, I think is quite important. And that's a good way, I think, of engaging the patient in taking, some kind of having a good understanding and taking some ownership, as it were, of and some I don't know what the best word to use is, actually just being very engaged with their own health and understanding what the right tests and the right things to look out for are for that individual, which could be quite different between patients.
That's really helpful, Chris. Adam, would you like to add to that?
Yeah, I was just going to add, for each, I completely agree with everything that's been said. The other thing that I think is helpful, just thinking about my specific field, but I'm sure the same thing applies across the board, is that I think more and more we're relying on patient-reported outcome measures. So, lists of potential symptoms and problems that folks should look out for when they're undergoing active monitoring. So in my particular field, there's something called the MPN-10, which is a list of 10 different symptoms that you can either give folks a sheet of paper, doing it the old school way, or there are apps to monitor your symptoms. And every so often, you just complete one of these. And that's quite helpful when you come for your intermittent appointments, however often those will be. It gives a good feel for how things are over time and whether there's any trajectory to some worsening of particular symptoms. So those kind of tools can be very helpful. Equally, it's important not to become too obsessional about them. So they're a useful tool, but you've got to be careful not filling them out 3 times a day kind of thing. I think there's a happy medium to be reached.
Absolutely. Thank you. Well, you've given us a nice segue there, time. And one thing we've heard a lot from patients on active monitoring is understanding the frequency of their consultations, their visits, whether if they're seen less frequently or more frequently, if there's any significance in that, and coping with the fact that they might not feel that they have as much care as they would have expected at diagnosis. So I'm wondering if you've got something you'd like to share on that, Chris. If that might be helpful for patients that are, using the old term, are worrying because they are not, they don't seem to be in contact very often.
Yeah, I think that's a good point. And patients patients are people, and people are different. And some patients like the reassurance of coming to the hospital frequently and having their bloods checked, whereas others are very happy and very reassured if you want to see them or need to see them less frequently. So there's an individualization to some extent. But as a general principle, we would try and keep the hospital visits and blood tests to a minimum, to the minimum safe frequency necessary to detect any changes in health. But whatever that frequency is, we always emphasize to our patients that if they're concerned in between appointments, they should get in touch with usually their clinical nurse specialist or another member of the team, because the chance, if you're seeing somebody perhaps 2 or 3 times a year, the chances are, if something is going to change, it may well change in between appointments. But for most of these conditions, the blood conditions that we're talking about on active monitoring change is usually gradual. There's usually not a sudden change in health. In rare circumstances, that can be the case, but for the majority of patients, things will change slowly. And so we try and therefore judge the frequency of a hospital clinic visit according to what we understand about how the disease behaves over time. And it may well be the case, it's often the case, that we see patients more frequently, perhaps in the first year after diagnosis, until we have a better grasp, a better feeling about what we call the kinetics, the rate at which their condition is changing, and usually on the slower side rather than the faster side. And then as time goes on, we have more confidence in extending the interval of their outpatient appointments. And so usually I would take that as a positive thing if I was a patient, and be reassured that you have the fallback, the safety net of contacting your team in between appointments and expediting the visit if needed.
Thanks, Chris. I'm mindful of time. Maybe we've got time for one other quick question, Stephen. Is that all right? I know we have to try to avoid it. I hope it's not permanent. But the one question about monitoring remotely. It was something that was obviously very experimental before COVID. We're now living in the COVID pandemic, and that's become more of a reality. I'm wondering if you've got anything you want to share on active monitoring more remotely. Is there an issue with this? Have you got anything you'd like to add to what Chris said, Adam? And maybe then we could just finish with a patient. I think that would be a really good to hear from John and Denise how it's impacting on them.
Well, I think, even though the pandemic has forced certain, decisions in terms of remote monitoring, I think, there was in general a move towards more remote monitoring over the last years since I've been a haematologist, much more than there historically was. So we were already pretty active in introducing telephone-based clinics, led both by our nurse specialist team and by the team of consultants. So that was already happening. But it is important to be aware of the potential limitations of that, and also to be aware that it's not for everyone, and also to be aware that we've got technological advances. So using video conferencing types of approaches are also coming into more routine clinical use. So I think even though there's been a very rapid step change in remote monitoring, I think some of that, where appropriate, is here to stay. Probably quite a lot of it, actually.
Thanks, Adam. Just before we move on, John and Denise, have you got something you would like to share with regards to in-person or remote as you're being monitored?
Yeah, I don't think I'm comfortable with it. Given the opportunity, I liked the ability to go into Warrington Hospital, have a face-to-face, have my lumps checked, and therefore I felt a bit uncomfortable with the telephone. And it also means a quick dash into the GPs to have a blood test, which has probably been a little bit more comfortable at the moment than going into the hospital. But I think to sum it up, the last 12 months, I have noticed my anxiety levels increasing. The previous 18 years, I'd come to terms with the whole affair, but the last year, I have been a bit more anxious, and I will be glad to get eyeball-to-eyeball contact again with my haematologist. I hope that was clear.
Here, John. Denise, please.
Well, I have to say, if I'd been initially diagnosed, then not being able to see the consultant personally, I think would definitely heighten the stress levels. But dare I say that because I'm sort of so many years on and I'm very comfortable with my consultant, she is very thorough. then I've actually felt quite comfortable, as John said, not having to go into the hospital, and know that she's a lady who really does listen to what I've got to say. And just to sort of reiterate on another point about my family, also give me sort of feedback, which I can then pass on to the consultant. So I don't feel particularly uncomfortable doing the remote consultation personally for me.
So this is really around kind of picking up on what's said. So I think generally both in lymphoma action, leukemia care, the services, the information we have is there to help people with a diagnosis and their families become more informed, because we know that the more informed people are, the better outcomes they have. And as both of you said there, you're either in the kind of area where you're having lots of tests and you soon become, perhaps Nick can say, you become an expert in what those tests mean, all of the different medical acronyms that they have around those tests, or you become more kind of vigilant and aware of changes in yourself, whether those might be around symptoms. So I think really this area is particularly around self-checking and self-monitoring. I think you touched on it, Adam. What you don't want to become is so obsessed that you're checking yourself every day, because actually some things might change, and that's normal, because that's what the body reacts. And if you get ill for something else, it might not be directly to do with your particular disease and diagnosis. So how do you kind of help an individual kind of understand that? What should they be looking out for? How often do they check things so they become that balance between vigilant and over vigilant? Adam, how would you?
Well, I think it's a process, isn't it? I mean, right at the beginning, as has been really nicely articulated, folks are often shell-shocked and mostly don't take in much of the information during the first consultation. And, then there's a process that one goes through between the patient and the rest of the team. And of course, very importantly, more and more so, advocacy groups with all the information provided online and so forth. So that's a process that you go through as people kind of learn about the condition and come to terms with it. And, as they learn about the condition and, build a relationship with their care team, I think that's when the process of active monitoring becomes a lot clearer to people. And I think the most important thing that I try and get across to people, certainly during the early phase, is we're here. We're always here to answer any questions. The nurse specialists are here, and there's all sorts of excellent forums that folks can join. And so if they've ever got any questions, they can always contact us. So the worst possible case scenarios for folks to feel that they don't really know what's happening and they're in the dark. So the most important thing is, if you've got any questions, you don't feel that one knows what's happening, get in touch with the care team.
Yeah, actually, Chris, really, you'd mentioned that yourself, where if you've got appointments every 3 months or every 6 months, that's a very snapshot of time, isn't it? But actually, a lot of, if things are changing, they would be changing over a period of time. And a patient themselves, that's the whole point of active monitoring, is kind of the best expert on their own health and their own what's normal for them or what's the change for them. So I was going to just say, John, from your experience over those 19 years, how when you have noticed a change, if you have, how did you go about kind of letting the medical team know, and how did you work with that team to raise that concern, and what kind of feedback did you get?
I'm particularly lucky that my GP surgery is top notch, and I know that if I phone at 8 o'clock in the morning, somebody will phone me back before lunchtime. And if necessary, in the old days, I was able to pop down and see them and get really, really good immediate feedback. Luckily, it doesn't happen very often, but the support I've had from my surgery has been so reassuring. because I know they're always there at the end of the phone. A bit like Leukemia Care. Sorry to put the advert in, but also they've been so helpful. And if I've had any side issues, for want of a better, I've just picked up the phone, and folk at Leukemia Care have also given me that support. And I am lucky in the fact my daughter's a GP, and if she's about, I get that support that Denise has talked about from my family, and it's lovely to hear that her family are supporting her like mine, and I think we're very lucky, and I hope other people have that network within the household.
Thank you. And so that's a very good example of kind of within the GP in the primary care setting. I think, Denise, you'd mentioned about your clinical nurse specialist.
Well, quite recently, actually, my family told me that I was losing weight, and I had been having a few night sweats. So what I decided to do was, because I'm sort of having a chat at the moment with the consultant every 3 months, I just waited until the next session, mentioned that, and I had a CT scan, and lo and behold, the tumours had grown slightly. So that was sort of dealt with just because I knew that I'd got the consultation coming up. But again, as John said, you know, family were great. They helped me to understand that I am being vigilant and not over vigilant, because you do lose confidence in your body.
Actually, that's a good point, perhaps just to finish on, Chris, where Denise was already had a consultation coming up, so perhaps waited for that. I don't know what the timescale was, but perhaps, but if people are your message to them, maybe if it's something that is a concern, don't necessarily wait for your consultant if it's a long way off, and therefore go back to those previous where that heightens anxiety. If something is a concern, do get in touch. It may be that it's not an issue, and that's great, but don't wait necessarily.
Yeah, absolutely. So I completely agree not to wait if you're concerned, but it may be that after an initial conversation with the specialist, for example, over the phone, and a discussion of the symptoms, it may be then that the advice and agreement is that waiting to the next appointment in 6 weeks, for example, is a very reasonable thing to do. But that decision is, after a conversation with a member of the healthcare team, the specialist team, or it might be that there are some, kind of so-called red flag symptoms or some concerning symptoms that are reported, and then the nurse specialist will liaise with the consultant and the appointment's brought forward. So, it's not just on the shoulders of the patient to make that decision about what's urgent and not urgent. That advice can be given following a discussion. And that's hard, and it can be hard because some of the symptoms, should I say, that we all advise our patients to look out for can be quite non-specific and be quite common in the general population and in general life. Everyone is sometimes fatigued, not uncommon to lose a bit of weight from time to time, or perhaps to have some sweat. So some of these symptoms can be vague, and it can be difficult for a patient to kind of have to decide about what is significant and is not significant. Usually we can kind of get a feeling for that through a conversation, but if there's any concern, then we do look to more objective tests, be it a blood test or a CT scan, to clarify any uncertainty. So that's the kind of the thought process that we go through when a symptom is reported.
Yeah.
Perhaps it'd be a good idea to ask you, Adam, as you introduced about the variety of conditions that active monitoring's employed in, and the nature of the conditions. Have you something you'd like to share on duration of active monitoring?
Well, I think it's it's important to set out the kind of trying to think of the right word, the factors that will lead to a change in that management plan for any individual patient. I think that is really important for people to understand when one's going into active monitoring. So what are the things that are going to alter that management plan? And that might be on the range of different things that we've been talking about. It might be something relating to symptoms or laboratory tests or some kind of scanning or imaging, you know. So I think it is important for people to understand, and this comes up quite a lot at the beginning of this process, you know, what are going to be the triggers for changing that approach. And you know, broadly speaking, when one stops active monitoring, in principle, it can go on as long as it's a successful approach, and as long as there aren't any triggers that warrant an alternative approach. The only, you know, I guess there's different types of active monitoring. There's active monitoring right at the beginning of a diagnosis in someone that's never had any treatment, and then there's folks who've had some kind of course of treatment and then are being actively monitored after that treatment is completed for possible recurrence of the disease that has responded well to the treatment. And at some point, in many situations, people will be signed off from that kind of active monitoring because you reach a certain stage beyond which the likelihood of disease recurrence is sufficiently low that there's little value in the regular visit. So yes, it is possible for people to get signed off from active monitoring, but I think that's a slightly different circumstance to the one that we're really talking about, which is broadly newly diagnosed patients who undergo active monitoring, and there typically that is something that is ongoing.
Thank you, Adam. That was really helpful. You covered a lot of ground there. Chris, would you like to add to what Adam's had to say on any of the nuances and topics?
No, so I absolutely agree with those points. Just looking at some of the other bullet points on the slide, you know, there is for each of the blood cancers, there is a proportion of patients who will never need treatment. One of the challenges for us as clinicians is actually being able to accurately predict who those patients are early after diagnosis, and this speaks to some of the things Adam mentioned earlier about risk stratification and trying to predict, use, you know, blood tests, often specialized blood tests or molecular tests, to try and predict what the trajectory of the patient's disease course may be. But we know from experience, from monitoring patients over many years, and we have John as an example on the call today, that there are patients whose disease remains stable, not requiring treatment over years and decades, and certainly there's a reasonable proportion of patients with CLL, follicular lymphoma, and some of the other conditions who a decade or more on have never required treatment and never will. We're just not very good at spotting who those patients are right at the beginning. But that's something I think will improve with science.
Now, it kind of gets to some of the crux. So we mentioned before that, you know, it gets really hit with people when they not only have they been diagnosed with a cancer or told they've got a cancer and they've got diagnosis, but they're not going to be actually their treatment is active monitoring, not going to do anything straight away. That can be quite a significant impact on people. And I guess I was really going to go to how did you cope with that, kind of, John, when you first heard that? I think you've alluded to it a little bit, but how was it explained to you, and how well was it explained to you, and how did you kind of deal with that?
The answer is it was explained to me, but the penny didn't drop.
Yeah.
So I guess if we were going to pick anything up out of today's communications, that kind of watch and wait, as it was called, you don't cotton on initially, but once the penny had dropped, it seemed okay, and the alternative, as I've already alluded to, was probably a bit more grim. So I was happy to drift into it and then start managing it in my own way. And I think it was important that once I'd come to terms with it, we made a good job of it. And I think you do have to be alert to what's happening to you. You follow your body and you look after yourself. And I think it's and I consider it an important message that if you are on active monitoring, you have to look after yourself. And if you look after yourself, you might be a bit like me and become 19 years into it.
And Denise, you'd mentioned about your family. So again, how did you how did you explain it to them about what that you had a diagnosis, but you were on active monitoring, and how did you address that about them wanting to help you but not kind of knowing how they helped you? How did you work that through?
Well, I think because I'd already had treatment and then had to go back on to sort of the monitoring when the lymphoma came back about 15 months later, there was this definite expectation by family that, oh, well, you'll be starting treatment again then. And it was, no, that won't happen this time because it's only just started and it's a slow growing cancer. So I think for family and friends, it was quite difficult for them to understand. And they actually got quite annoyed as to, well, why aren't they doing something? You know, what do you mean that they're not going to start treatment? But eventually, I think as John said, you know, the penny does drop that actually you are being monitored and that's the best way forward.
Yeah. No, thanks for that. I think we've already covered the kind of from Chris's and Adam's point of view, how do you explain it to individuals? But perhaps you can add, Chris, so not everyone kind of necessarily understands that, or that has significant kind of impact, particularly psychologically, on them. What kind of help and advice is there available within the kind of hospital setting, either through yourself or through clinical nurse specialists, or even through referrals that you can make to help and provide some of that support?
Yeah, I think there are a number of ways to support patients. There's one of the most important things is the consultation with the consultant, and it's having a patient having an understanding to their satisfaction, and that will differ between patients, how much information they want to have and how much detail they want to know. Everyone has a different kind of appetite for the level of detail. And that's followed up then with support from nurse specialists. There are things that consultants will have missed, or there will be things that patients may have chosen not to ask or have forgotten, and the nurse specialist is a good way of picking up some of those elements. And then for patients who perhaps are really struggling to come to terms with the active monitoring approach, some patients may need further support, and that's when patient advocacy and charities may be really important, and that could be blood cancer specific charities like Lymphoma Action, Leukemia Care, or it could be the broader cancer charities. We have a Maggie Centre in Nottingham, and I'm aware not all centres do in the UK, but they're a really great kind of a non-clinical area for patients to go and get general support and advice. Yeah. And then, of course, for a minority of patients who perhaps are struggling psychologically, there should be access to a clinical psychologist. And I think access to such a service is better than it used to be. I think it's still not good enough in terms of the breadth and depth of psychology support available, but it's there for patients who need it, and we should be able to refer on to that for the minority that require that extra help.
Yeah, thanks for that. Yeah, so that's a good point. So again, Lymphoma Action, Leukemia Care have a number of services or information or ways of getting in touch with them to explore what those sorts of things are available.
I suppose the real question is, we need to look at living well strategies and coping strategies to help live with what looks like it's for the long haul. Yeah. So I don't know, Denise, you touched early on in your introduction how you'd like to help others, and with information you could share. So I'm just wondering, do you have particular coping strategies you'd like to share that you've...
Yes, thank you, Nick. Well, I have got involved as a buddy within the Lymphoma Action Group, and I've done that for many years. So that's my way of sort of supporting, and that's great because you can really sort of support other people through you know, your own experiences. The other thing is I try to get a lot of enjoyment out of life. So whether that's taking the dogs out, you know, by the seaside, whatever it might be, and just enjoying the feeling of being alive. I think that's the best way to put it. And finally, my husband and I, we both have a very warped sense of humour. So, for example, when I've been to see the consultant and got the other, you know, the sort of all clear for another few months, he usually will turn round and say, "Oh no, wife number 2, I'm going to have to phone her. She's going to have to wait again. She's going to get fed up with this," you know. So we could sort of have a good old giggle, and that helps. So it's really about trying to keep that. I know it sounds an awful word, but the PMA, you know, the positive mental attitude, and finding the simple pleasures in life, and trying to find the humour in sometimes which are very stressful events in your life.
Thank you, Denise. That was really positive, really interesting. I'm going to ask, before asking you a question, John, because I know you're keen into the exercise side of things, I wanted to just ask the healthcare professionals, doctors, if there are any particular lifestyle coping mechanisms of diet or exercise plans that might be beneficial, as the bullet points here are noting. And, you know, are there limits to how much exercise is recommended?
I think I think this is such an important area.
Yeah,
it's so important, and I think one of the frustrations is there's so much we don't know actually in answer to this question, and it's really, really important for patients, particularly patients on active monitoring, but all patients with blood cancers, and it's a really under-researched area. So we don't, you know, whilst we've got really rigorously collected clinical trial data on all sorts of interventions and things one can do in terms of drugs and other types of therapies, actually for lifestyle factors, the data is much, much weaker. So it's a little bit of hand waving typically when one answers these questions from patients. But I think then it just becomes a kind of common sense thing that it's really down to individual patients. You know, there's no point asking someone that's never done any exercise in their life to say, oh, right now you've got to suddenly start doing an extreme exercise program. It doesn't make sense. I think one has to do everything in a sensible, balanced way. Too much is equally as bad a thing as too little. So getting that sweet spot right in terms of diet, in terms of lifestyle factors like exercise, I think is down to each individual patient. I think we need much more research in this area. That's the bottom line. You know, just to give you a flavour of that, there was a really tantalising clinical trial that was done on yoga. So yoga in patients with myeloproliferative neoplasms, and it was actually a randomised trial. So folks were randomised to have yoga or not in a kind of rigorous prospective kind of trial fashion, and that showed that yoga, regular yoga, improved a number of important symptoms associated with the disease. That's the kind of thing, in order to really properly answer your question, that's the kind of thing that we need to do. We need more rigorous kind of collection of data.
Adam, that's really useful. Maybe we can set you both a challenge as you're both into research of seeing if we can get the community behind you with some of these kind of studies. I'm mindful of time, and I'm also mindful of circumstances at the moment, and it's something we can't avoid. I'm going to ask you, Chris, about this. Obviously, we can't avoid that the patient community that we're serving are an immune-compromised population, and some to more degree, different degrees than others. And I think patients outside of COVID, before COVID, when they were, you know, first diagnosed and realised that they potentially were going to either be or enter a compromised immune state, that they would take on board strategies to cope with it in that time, which is pre-COVID, and now COVID has added and exacerbated this. I'm just wondering if you've got anything you would like to share there about the issues for patients who are immune compromised, and how you can live during on active monitoring without being obsessive, and learn to understand, if it's possible, your own level of immunity compromisation, so that you can cope?
Yeah, I think it's obviously a really topical issue, and it's really important. I think it's really hard to communicate to patients about the different elements of the immune system and the different and quantifying in some way how good or bad or indifferent someone's immune function is. It's actually quite hard for us as clinicians to measure it, actually. I mean, we have some tests we can use to look at the different lymphocyte subsets or antibody levels and so on to give a feeling about how immune compromised the patient is or isn't. But it's not an exact science, so there's a lot of unknowns there. So certainly when it comes to vaccination, you'll know even before COVID hit the world, in the world of CLL, we were very proactive in encouraging vaccination for the things we can vaccinate against, so pneumococcal, the pneumonia vaccination, as well as the annual seasonal flu vaccine, and we would always recommend our patients to have those, the flu every year, pneumococcal as soon as possible after diagnosis when the immune system is probably still quite reasonable. And then of course COVID, and I think we still have a lot to learn about the COVID vaccination effectiveness in patients with blood cancer, but the easy recommendation at the moment is everybody should have, everybody should have the COVID vaccine. Even if it doesn't fully protect someone who's immune compromised, then even some level of protection may reduce that risk of hospitalization or any serious consequences of the virus. So I would very strongly encourage patients to have all vaccines except live vaccines, which COVID is not, all vaccines that are available, because the protection they can offer may not be 100%, but it's certainly worth having.
Really, that's all we've got time for today. We're just going to quickly move on to thank you everybody for joining us. So thank you, Adam, Chris, Denise and John. Sorry that we haven't been able to get to you on the scene, but very, very invaluable contribution from both of your perspectives, and hopefully other people hearing from your perspective about being on active monitoring has been helpful as well. So thank you very much. Those are our contact details, and we'll see you soon. Okay, bye-bye.
Bye-bye. Thank you, everybody.
Bye.
Bye-bye.
Thank you. Bye-bye.